Okay, so as we look at the Unit 8 portfolio, the cardiovascular system, um, again, the terms are focused primarily on structures. So there shouldn't be too much in here. There might be a few items that seem a little bit physiology based, or there's maybe a couple about the conduction system, which we didn't really get into. We saved that for next semester. In fact, I think it's right. Yeah, there it is. Describe the cardiac conduction system. So, but really, your focus is primarily on identifying all of these different structures that you find. So this is part one, the lymphatic and immunity. I'll pull that one up as well. So anyhow, the next section of identification, I think these are all fairly straightforward. We can see, we talked about them with vessels on Tuesday, but we could see the three kind of conducting vessels or arteries that come off of that aortic arch. We had brachiocephalic, and then left common carotid, and then left subclavian. It only wants you to label the first one. I think that might be the rest of these. I think you are pretty straightforward. We've seen them before. Wants to know just some of the specific chambers. So E and F are the right side chambers. Okay. And then J and K are going to be the left chambers. Letter L is actually pointing to what we call the apex of the heart. So that's there as well. And then some of the key features we talked about really throughout, I think it was last Thursday when we went through the heart. So I think most of these are recognizable, and you shouldn't have any trouble identifying. There is one here, letter R, that we didn't really go through. So it's a specialized band. So again, you can, I wouldn't worry too much about letter R. In fact, if you left it blank, you would be fine. And then the pathway of blood, starting at the superior vena cava, we dump into the right atrium, and then the tricuspid. And this could say superior / inferior vena cava. Some students have put inferior vena cava in the first box, so don't do that. It's wanting to know from the superior vena cava, where does the blood go? It goes into the right atrium, past the tricuspid, right ventricle, pulmonary valve, pulmonary arteries, and then out to the lungs, back to the heart via the pulmonary veins, left atrium, and then mitral or bicuspid valve, and then left ventricle into the aortic valve. And then we had our layers of blood vessels that we went through on Tuesday. We have the three tunics, the intima, media, and externa. So you want to take a peek at those. And there's a valve over there with the vein. I think I eliminated this arteries versus veins box. I don't think you guys have to do that. And if you did, you could do it without any trouble. Couple of blood vessels that you're going to want to look at as well. Starts getting into, again, pretty straightforward with these. I tried not to get too tricky. Again, with labeling of blood vessels, they're named generally for where they're located. Now, these images are straight from visible body, so you can access those from visible body. Same with this one. Yeah. And these are all arteries first, So letter G is pointing to an artery. Letter F is pointing to an artery, ulnar and radial. Okay. Then we get into some veins. And again, letter D and letter C are a little tricky. The C is that cephalic vein, okay? And then the basilic vein for letter D. Those are probably the trickiest couple on there. But again, these are in your PowerPoint that we went through, and they're certainly going to be in visible body as well. Okay. I think most of those are pretty straightforward. There's a couple of, I think I removed the apply what you need. And I think that was just about it for the cardiovascular aspect. And then I'm going to pull up my screen shares pause. You're not going to see anything at the moment, but I'm going to pull up the blood and immunity because I combined the two. So the two that we're looking at. Okay, let me. Oh, hi, Jasmine. How are you?
I'm all right. My
Cool.
family is doing some work on the house, so I had to help them. That's why I was late.
Oh, you're right on time. Yeah, no problem. And I recorded, so whatever you missed, it is recorded. I'll put it into YouTube. I'm going through the week 8 or the unit 8 portfolio. Your your guys' portfolio is too condensed into one. I have my keys separated, so we went through kind of the cardiovascular, the vessels, and the heart. This one goes through blood and lymphatic, but again, your guys is combined, and which again, I'll pull that up in Blackboard in just a second. Um, anyway, there's a couple items on blood specifics, and then it gets into. I'll slow down. So you can, if you need a pause or anything, you certainly can. Okay. Couple different diseases and disorders. All I'm looking for with these, the penias and the philias, if you ever see those terms, philia means kind of lover of, affinity for. So typically we think of an increase in something. So like hemophilia, increase in red blood in blood. And it's not really what it means clinically, but just breaking down the terminology. We may see neutrophilia. So you've got too many neutrophils or something like that. So if you see penia at the end, it just means not enough of something. So penia, P-E-N-I-A is the opposite of philia. So anyway, if you ever see those are more like pathology terms. So I mix in a few pathology terms this semester, but for the most part, I think you guys have pathology, a specific course. So, all right. So anyway, components of the blood. Again, we see plasma, red blood cells, and then the buffy coat there in the middle. And then this one, blood typing. So your answers will vary. Just is going to depend on your results. So there's a spot in there. There's a website you're going to want to click on. It's very straightforward. It goes through a couple of different basics of blood typing. You're looking for clumping, or they call it glutination or coagulation. You might see that term, but clumping is really what we're looking for. And when I put an when I put an antibody that is causes clumping, if it's an antibody against A, so anti-A antibody, that would be contained in B blood. So if I put an anti-A antibody in a sample and it clumps, then we know it's not going to be B blood. It's probably either A blood or AB blood, because AB, we would have both samples clumping. So keep that in mind when you do the blood sampling. I think the two that are straightforward. So you have 4 patients and you have 4 blood types. So it's likely you're going to have an A, a B, an AB, and an O patient. So the O, when you do the anti-A antibody and the anti-B antibody in 2 separate, you know, wells, we call them, in the clinic. I don't know what they'll call them, slides maybe, on when you guys are doing the virtual lab, but you're going to have a patient A is going to have 3 drops of blood. The first drop of blood you'll put anti-A antibody. Second drop will be of blood, you'll put anti-B antibody. And the third drop, you'll put anti-D, it's called, which is the RH factor. So which we'll get to in just a second. If in the first 2, You get no clumping in either one of them. So no clumping in either, then that's O blood type. If you get clumping in both of them, it'll be very obvious when you see it. If you get clumping in both of them, then it's AB blood type. Okay, and then if you get clumping in the third one, the RH, the anti-D, that one, if you get clumping there, that's RH positive. So positive for clumping means it's a positive and RH antigen. And again, if only one of the first two clumps, if you don't get clumping in the RH one, then it's negative RH. Okay. So again, if in the first two, if you get clumping in one, but not the other, then it's either A or B. It's one or the other. So which one is it? If one clumps and one doesn't. If it's anti-A, that clumps. So anti-A means pro-B. If it clumps, then that is not B blood. Okay? If it doesn't clump, then it's B blood. All right. If anti-B, which would mean A blood affinity, doesn't clump, then that's A blood type. If it does clump, then that's B. So anyway, we'll go through blood typing in advanced again, and then you'll do it again in your clinicals. So if you're a little bit confused about blood typing, this virtual lab will help you, first of all, be less confused. And if you're still kind of confused after that, again, if you can get that O is nothing, no clumping, and AB is double clumping, then you're good on that. And then you just need to work on figuring out, okay, again, just think of it this way: anti-A antibody means against A. So that means it's pro-B antibody. So if there's no clumping, then that's positive for B blood. It's pro-B, it blends with the person's blood and there's no clumping. Hey, if anti-A clumps, okay, then that's A blood type. Okay, pro-B can't go, which is also anti-A, can't go with A blood because it's pro-B. Okay, so if we do put it with A blood and we see clumping, then we know that that is definitely not B blood, that's possibly A blood. All right, if they both clump, then it's AB blood. So anyway, I know it's a mouthful. We went through it a little bit last Tuesday, about 10 days ago or so. So I put this virtual lab in so you can kind of clear that up a little bit. And again, we do it next semester in advance. So, and if you haven't registered yet for advanced, make sure you get to doing that. Registration is open. There are several blended courses that would meet, I think, 2 hours a week in person, and then I've got a couple sections of online. So, so anyway, make sure you register if you haven't already. Let's see. Identification of different blood aspects, right? We see some red blood cells, of course, some white blood cells. Okay? Remember, the white blood cells have a nucleus, so they're going to stain really loudly. Okay? And then we see some granular, okay? Some granular looking. See, A and A both have granules. F and G have granules. So we know those are philic, right? Those are the fill group if they have granules. Okay. And then we had kind of the triple chunked look or appearance of the nucleus. Hey, and then kind of a lighter, just kind of a neutral looking color. It's not in the cytoplasm. It's not really dark pink. It's not dark blue or purple. It's just kind of a mellow purplish, light lavendery color. That's a neutral color. So that's a neutral fill. When we look at F, and these are the most likely that you would see if you did see white blood cells on a blood smear. these are the most numerous. So you'd likely see some of those. Now, these other two granulocytes are much less numerous. So if you did see any of these, if you saw maybe one on a blood smear, probably it wasn't that big of a deal. I mean, you can move a blood smear or slide around while you're looking at it to get different, different areas covered on the slide. So, and there's a grid in the eyepiece, so you can see it sectioned in measurable increments. So then you can see how many of X cell is in this particular amount of blood. So anyway, we usually don't see, my point is we don't see very many bright pink granulocytes or dark violet, dark purple granulocytes. Remember, pink is acidic, so this would be an acidophil. Dark purple, deep violet, that's going to be baso or a basophil. And then we've got, of course, the erythrocytes, and then the tiny buggers are platelets. Okay, so you usually see a few platelets on a blood smear. And then letter C and letter D. Letter C, we know C and D don't have a lot going in the way of granules. We also see very large nuclei with both of these. So that's a signal that we're probably looking at some sort of a site, a granulocyte specifically. And you only have two of those. It's either a monocyte or a lymphocyte. So lymphocytes are not a heck of a lot bigger than red blood cells. So that's something to look for. You can see they're a little bit bigger, but lymphocytes also have that enormous nucleus. So they're the second most numerous of your white blood cells. So these these neutrophils up top, letter A, and then these lymphocytes, these are going to be the most numerous. So if you see white blood cells on a blood smear, it's likely going to be one or the other of these. And then letter D is the largest of the white blood cells, or one of the larger white blood cells. It's 2-3 times. It gets up to a red blood cell is 8 across. 8 microns is the unit, but just think it's around 8 across. These are about 8 to 10, 8 to 12 across. These can get up to like 18 to 20 across, so they're quite a bit bigger. But anyway, that's going to be your monocytes. Or those are going to be monocytes. All right. And then I don't think I had anything with questions like this. I think I took those out. And again, focusing primarily on identification. We see a couple of items. Letter A is a little bit tricky. It's pointing to something that isn't really there. That's pointing to the appendix. Okay, letter A. The appendix is, they've kind of concluded that it has a role in the immune system. Okay. Has to do with your intestinal flora. We'll talk more about the appendix on Tuesday. But anyway, that's your lymphatic identification. And then I think that's about it. Yep. So anyway, you guys should be good on those. So make sure you get those plugged away at over the next couple of weeks. All right. And then I wanted to go back into, I need to do a new share, stop share. Okay. So now we're going to go back online, back into the internet. Okay, so we're on Blackboard now. We go into Unit 8, and again, you can see the OpenStax. It has what sections. You don't need to read all 4 chapters cover to cover or beginning to end. You can simply go with 19.1, 20.1, 21.1, and generally all of Chapter 18. And then 20.5 gets into some of the blood vessel specifics that you'll be able to find when you're doing your ID or identification exercises. So anyway, there are two Padlets, so you'll want to click on those. There's a blood heart Padlet and a vessels and immunity Padlet. These folders have OpenStax direct links in them. And then the assignment that we just looked at over here. So again, we looked at the two separate ones. So there's about 64 things terms to define, and the rest of this is pretty straightforward, I think. Primarily identification, and then that blood typing website is in there as well. Then both exams, 8A and 8B, there we go. The test banks are a little smaller, so that's a good thing. So you should be able to go through these, and again, next Tuesday, if you guys, you're a small group, and if next Tuesday or when we get back from Thanksgiving, we'll have a little bit of time. So if you want to work on these, I know that was beneficial to you when it came to taking your Unit 7 exam, 7A. So anyway, this one has about 90, I want to say. 97. So the first one, 8A, has 97 questions, and then 8B, I think it's pretty skimpy. I think I was tried to get around 70 questions out of this one. I don't know if I did. So let me see. I think it was around 70. So anyway, not as many, not too bad. So this is, there you go, 73, lymphatic and blood vessels. Okay, and then the two exams, and then the hyperlinks for those, of course, are going to be off to the side. Okay. Well, let's keep moving. Let's go into the respiratory system and look at a couple of items there. The Unit 9, and let me go back over here real quick. The Unit 9 folder is just about ready. It's open for you. It is available. I don't think any of you are quite ready yet to move into Unit 9. You're still working on Unit 8, I would assume. Maybe some of you Unit 7. I don't think any of you guys are working on it, but you might be, which is fine. But anyway, Unit 9 folder is open. It does have the OpenStax folders with it. It has the assignment and portfolio. This you're not going to be able to see yet. I'm still working on getting the Padlets uploaded in there, but I do want to start on Unit 9 now. Respiratory system is very brief. We're not going to spend a heck of a lot of time on it. We do spend quite a bit of time on it. In fact, let me get, I'm going to put the slide link into the chat so you can access that if you'd like. But yeah, we're really we spend quite a bit of time on respiratory physiology next semester, so keep that in mind. Really, our goal today is to just look at a couple of the basic structures. Pardon me. Look at a couple of the basic structures of the respiratory system, more or less kind of the macro structures. And while we're doing that, we'll also be able to see, there you go. There's the link for that and I'll also put the link in Blackboard so you can access it that way. That'll link you up to the respiratory system PowerPoint. But anyway, yeah, they're just basically we're going to follow the path of air as it flows through the respiratory tract. We'll look at a little bit of the structural anatomy on the micro scale, but generally we're just going to focus in on the key structures, the more macro structures. Okay, so respiratory system is chapter 22. And again, your focus is really just going to be on 22.1. You're going to look at the rest of that chapter next semester, when we start getting into tidal volume and lung capacities and residual volumes and all of that good stuff. That's all physiology. So again, your focus as you're looking through the chapter is to really just stay in part one. What structure is it? We've already looked a little bit at the lungs. We know that the heart is involved with the lungs in some way. We also know the location of the lungs. We've seen this really from day one, right? We know that this is the thoracic cage or the thoracic uh, uh, cavity where we find the lungs contained again with the heart in that mediastinum. So the lungs are going to be directly linked with the heart as well as the diaphragm. We see the term pulmo or the combining form pulmo when we're discussing lungs. So and which again we saw last week, we saw the other day when we started looking at when we got into the heart, we got into blood vessels. We saw pulmonary arteries and pulmonary veins, both having to do with delivering blood away from the heart and then blood coming back to the heart. So none of that is that new. We also know a little bit about the functions already of the lungs, simply uh, because the whole point of sending blood from the right side of the heart to the lungs and then taking the blood back from the lungs to the left side of the heart is to exchange gases, primarily, right? Oxygen and carbon dioxide. We want to get rid of carbon dioxide and bring in oxygen. So there's your function right there. Done. Lung function, respiratory function is gas exchange. Now, there are a few other functions, of course, kind of going along with that gas exchange aspect. Is The respiratory system is your primary regulating mechanism for balancing pH. So, when we talk about acid base balance or pH balance, in the body, we're really talking about hydrogen ion concentration. And there's a small range that the body systems, including the tissues and the organs, tissues, and cells, really like to stay within. And that range is right around what we call the neutral range. So the pH or the hydrogen ion concentration is 7 or 10 to the negative seventh, which we'll get into more of those specifics next semester. But generally, when we get out of that 7 range toward maybe the acidic range, so lower pH, that means potentially that the lungs aren't doing enough work. And then so the kidneys are going to be your secondary uh, uh, I guess, system, the urinary system for regulating and balancing pH. So you will see a question at some point in your lives. You'll be asked on an NCLEX or a TEAS exam, what body system regulates pH? So you're definitely going with respiratory. Okay, respiratory system regulates pH. It's very, very important. And it's so important that we spend at least 2 weeks, maybe more, going through how pH is regulated and how the lungs play a major role in that when we get to physiology. So uh, we know the lungs are a part of the respiratory system. So we're going to back up just briefly and come up top. We probably know that our noses are involved with breathing and the respiratory system. Maybe a little bit the oral cavity, but we generally like to bring air in through the nose. And you can certainly exhale through the mouth, but the structural aspects of the nasal cavity do encourage us to be bringing air in through the nose. We need to humidify the air a little bit, especially this time of year. It's really dry. So the air we're breathing has to get humidified. We need to clean the air, filter the air a little bit as well. And then we also need to be able to, we need to humidify it. We need to filter it or clean it and we need to warm it up a little bit because the inside is 98.6. Out here is usually lower than that. So part of bringing air in through the nasal cavity and the sinuses is basically allowing the air to warm up a little bit before it does hit the lungs. So we'll look at the nasal cavity and some of its specialized features. We'll also look at kind of the back of the mouth area. We call that the pharyngeal region or the pharynx. So we'll look at the pharynx, and then the voice box or the vocal area we call the larynx. So we'll look at those in a little more detail coming up. We'll talk about tonsils briefly again. We'll talk about those eustachian tubes briefly again as well. Hey, and then as we enter into the kind of what we call the lower respiratory tract, so the upper respiratory tract, we'll probably look at that first in more detail. Okay, the upper respiratory tract, basically from the tip of the nose, what we call the nares or the nostrils, right down to the larynx. And then once we pass the larynx, we enter into the lower respiratory tract, and that's where we're in the windpipe or the trachea. So we'll look at some of the details of the trachea. And then the trachea branches into two large what they call bronchi. One is called a bronchus. So and I'm sure you guys have had or heard of hopefully you haven't had it, but I think that most all of us at some point of our lives have had some sort of lower respiratory infection, maybe bronchitis. So that's going to be the inflammation of these bronchi, which are the little, they're not little, they're fairly large branches off of the main trunk or trachea. We call this the respiratory tree. It's kind of an upside down tree. We have the trachea or the trunk, and then we have two big branches or bronchi, and then we'll see smaller and smaller bronchi till we get to what we call bronchioles. So again, we'll see that it does look a lot like a tree, and bronchi and means branch. Bronchiole means little branch. Hey, of course, we'll see the ribs protecting the lungs, and then the diaphragm connecting to the inferior aspect of the lungs. So again, first off, when we look at where respiration begins, we're going to begin in the nose. These are called nares, your nostrils, Nares, nares. Okay, so air is going to pass through the nostrils or the nares. We're going to enter into what we call the nasal cavity. Okay, the nasal cavity. The entrance just past the nares or nostrils. They call that the vestibule. Just like when you go into Walmart, or the claw machine is, or the sell your cell phone machine. Oh, Redbox is in there. That little area. They've got a person in there, with their tablet counting you as you walk in. That's called a vestibule. Okay. Oh, almost seems like all buildings have them, right? The college has a vestibule. We've mentioned that term before. So here it is again, vestibule. That's kind of the entrance of the nose or into the nasal cavity. And then we have three folds. We call these conchae, 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 kind of like a conch shell. Kind of that curved shell you put up to your ear and hear the ocean. So these are like kind of shell-like curves that they direct air flow. So the conchae are there for a couple of reasons. They are folded or curved, so they do increase surface area. We're going to see in the body that folds, especially next Tuesday when we get to digestion, man, we're going to see folds all over the place so we can optimize absorption. So surface area goes way up when I start making folds or curves. So we need more surface area to in the nasal cavity so we can do a better job of filtration, do a better job of warming the air and humidifying the air. So those conchae do help with some of those features or some of those processes. Okay, and then we have the sinuses. We've seen these before. We looked at the skeletal system, and you guys had to identify the different types of sinuses. We saw the frontal, sphenoidal, ethmoidal sinuses, and then they don't show them here, but we also had those maxillary sinuses underneath the eyes, the maxilla. Okay, maxillary sinuses. So you've got some big sinuses up here. You can feel them too. When they're clogged up, or when they're swollen a little bit. So anyway, air is going to get directed because of the position of these conchae. Air is going to get directed to different areas and different sinuses. Okay. So as we leave the nasal cavity, oh, and by the way, too, the nasal cavity, the whole respiratory tract is going to be lined with pseudostratified epithelium. So, going all the way back to week 2 or 3, when we were looking at tissue types, pseudostratified epithelium is going to be ciliated. We're also going to see goblet cells. We're going to see mucus production. So again, the lining or the epithelium of the nasal cavity and most of the upper respiratory tract, we do see a little bit of a change back here in the back of the mouth. We see a switch from that pseudostratified epithelium to more of a uh, stratified squamous and stratified cuboidal looking appearance back in the pharyngeal area, and then it starts back up again. And when we get further down toward the trachea, to being pseudostratified ciliated columnar epithelium. Okay, so again, why do you have cilia? To grab up debris. Okay, so there's a lot of microparticles, a lot of dust and dander, and so that those cilia are going to help with that. We know that the linings of the sinuses also possess that same epithelial structural lining. Okay, humidify the air, clean or filter the air, and then heat it up a little bit. So that's the whole point of this upper respiratory tract, especially the nasal cavity and sinuses. Now, as we start to go a little bit deeper into the nasal cavity, we're going to work our way toward the back of the mouth. But before we get there, we're going to be just above the soft palate. So when you run your tongue across the roof of your mouth, it's very hard. That's the hard palate, primarily the maxilla. Then you start to hit the palatine bone, and then everything gets kind of soft toward the way back. That's right in here. That's that soft palate, and just superior to that, or right above it, is where we're going to have the beginnings of what we call the pharynx. Okay, the pharynx. That's kind of a funny word, right? Phary, fairy, and then an nx on the end. Pharynx. All right. So the nasopharynx. So we'll see 3 sections of pharynx. The first is the beginning that's connected with the nose. So we call that the nasopharynx. Okay, the nasopharynx. And then we travel a little further down, and we see that uvula. That's that little dangler in the back of the throat. And just kind of behind that, or posterior to that a little bit. And then the area where you can see the tonsils, and then the way back of the throat. That's what we call the oropharynx. Okay, oropharynx. Yeah. See that term right there. And then we go a little bit further in, and we have what's called the laryngopharynx. So that part's a little more difficult to see. That is an area that's going to be just past the tongue. This is where this area, this whole oropharynx, laryngopharynx, hey, the oropharynx is where two systems are going to be using the same space. So we have to keep that in mind as well. This is where the digestive and respiratory systems both kind of meet up right there at that oropharynx. Okay. So before we get into the laryngopharynx, I guess I kind of already have, but before I go any further with it, there's something else I need you to notice too. We have the tongue, of course, and then right here, we could see almost like an extra tongue or a large kind of cartilaginous flap. This is called the epiglottis. Glotto or glosso means tongue. So this kind of means upon the tongue. But yeah, it's like a kind of an extra specialized flap. Now, we need this flap. It's very important. Okay, because as we swallow food, we need food to go into the esophagus, which is the your food tube. We definitely don't want food or beverages going into the windpipe or the trachea. And so the epiglottis is going to close off the respiratory system when you swallow something. Okay, so when we swallow, when we're chewing food or when we drink something, the tongue flattens out. Okay, so the swallowing reflex, that tongue's going to flatten out. And when it does, you can see this is kind of like the hinge right here of the epiglottis door. You kind of see this and notice too, it's connected to partially to the hyoid bone. Okay, so again, we see that the kind of the hinge of the epiglottis. As soon as the tongue flattens out and we swallow something, that's going to close this epiglottis door, and then the respiratory tract is going to be closed off. Okay, so the oropharynx and laryngopharynx are both part of that the respiratory and digestive tract. So we want to keep that in mind as well. Okay, and then of course the epiglottis has to shut in order for food and beverage to stay out of the windpipe or the trachea. All right. So that's those are the main components of the upper respiratory tract. We do include the larynx as well. The larynx is basically the dividing line. It's kind of like the diaphragm separating our thoracic cavity and our abdominal cavity. We've got the upper respiratory tract from the nose down to the larynx, and then the lower respiratory tract from the larynx down all the way to what we call the bronchioles and then the alveoli or the air sac. So we'll look at that in just a few minutes. But that's the primary, those are the primary structures of the upper respiratory tract. And again, we'll look at the larynx as well in a little more detail. That's your voice box. Larynx. So kind of like pharynx, then we have larynx. The larynx again is your voice box. Here's what that epithelium looks like. This is hopefully doesn't bring back any PTSD or bad memories going back into the tissue chapters from the beginning of the semester. But I think at this point in the semester, we've seen enough tissue slides and discussed it enough that all of you, I think, are pretty comfortable when you see something that looks like this. But we do have the lumen of the trachea, for instance. This could also be the upper respiratory tract. This could be the nasal cavity or the sinuses as well. We do see that pseudostratified epithelium, and then the cilia on the top, and then all of these goblet cells. They're kind of these lighter structures that we see. They're like little containers that are going to secrete mucus onto the surface of that epithelium. So when debris or dust and dander and other gunk gets passes into the lumen, these cilia are kind of sticky, so they can pick up a lot of that dust and dander. We also have mucus production normally, right? We need that respiratory tract to be humidified, so the mucus does help with humidification. Certain viral infections, bacterial infections as well, but generally a lot of viral infections that we think of that attack the respiratory system. It could be a rhinovirus, coronaviruses do it. And by the, coronavirus is COVID-19. Coronavirus is a big, broad umbrella of multiple different viruses. You may be heard of SARS. That's another one in that category, subacute respiratory issues. And so anyway, these viruses go after some of the the way the goblet cells produce mucus. So we oftentimes will get hyper mucus production, oftentimes due to other immune factors that have almost an autoimmune response. We're finding with COVID-19, there's almost like an autoimmune response gets triggered, and your immunity goes hyper crazy, trying to basically keep up with what it's producing to fight COVID, the coronavirus, COVID-19 specifically. So it does create a whole bunch of gunk potentially in the lungs. It makes it very difficult to breathe. So anyway, the cilia help with kind of moving all of that gunk that gets stored up down there. It helps to move that out. So but yeah, I mean, if you're smoker, or if you've been around smoke, or if you've been around, some people have pollen and mildew and mold and dust allergies. And if those are high peak, farmers, a lot of farm folks, they, certain times like crop harvesting season, creates a lot more dust. And so anyway, that, some people have more goop in the morning. We're finding that a lot of foods can trigger excess mucus production and get people kind of gunked up, we call it. So like your sinuses get gunked up, everything gets gunked up. Sugars, refined sugars definitely do that. We see like orange juices and milks. These are real mucusy. So they do tend to create more cheeses. I know we're in the cheese state, right? Dairy state, ice cream and cheese and yogurt. We ship that out, right? But anyway, yeah, butter, cheese, yummy. Ooh, bring it on, right? Plenty of milk. So those are all very mucusy foods. So we do tend to see a lot more chronic upper respiratory issues. We have dramatic seasonal changes as well. A lot of farmland, like I said. So there's a lot of chemicals and pesticides. There's a lot of dust just in general. Um, we're pretty urbanized as well in certain areas, so the air quality there, and cars everywhere and factories. So there's a lot of work that our respiratory system is doing to try and kind of keep things clean. So that's why it's extremely important for you guys and all of our patients to stay hydrated, to work on stress reduction and breathing techniques, and being more aware of diaphragmatic and deep breathing, and just generally be more aware of what they consume as well, because again, too much sugars and mucusy foods can lead to more mucus production in the respiratory tract. So anyway, so this kind of blows up what we just talked about, but puts a couple nice pretty colors on it. Again, we have the nasopharynx, the oropharynx, and the laryngopharynx. Yeah, so you can see how the pharynx is divided, how they highlighted it a little bit better than what we see here. And then it takes us over to the voice box, or the larynx. So as the laryngopharynx, or the last part of the pharynx kind of ends, we meet up with the larynx, or the voice box. This is an anterior view. This is a side view, or a lateral view. This would be a right lateral view. So looking at the voice box from the right side, this would be the anterior portion out front. Okay, so again, this we can see this epiglottis a little bit better. It looks like a little tongue, right, from the anterior perspective. So you can see that's the tip of it right there and right there. So right there, we're looking at the epiglottis, and then the hyoid bone. So we can't see this without a tongue depressor and a light. So you can't probably look in the mirror and see your epiglottis very easily. Okay. And then here's the peak of it right here. So when we swallow food, the epiglottis is going to disappear toward the back. It's actually folding over top of the voice box, or the larynx, kind of preventing food and water from going down into your respiratory system. Yeah, so that's really the main thing I wanted to show you on here is the epiglottis and the hyoid. And then we have what's called that thyroid cartilage. Thyroid cartilage, the thyroid's in the throat, the anterior portion of the throat kind of wraps around the larynx or the voice box. We have what's called the laryngeal prominence, and this is also known as the Adam's apple. So we tend to see thicker folds of the voice box and the vocal cords and the vocal folds in males than females. So there's a little bit more of a laryngeal prominence. Now, uh, females have it too. It's just more pronounced typically on a male. So it's not men have it. Or males have it, females don't. It's more a matter of how much of it, how prominent is it? More prominent it is, typically, the deeper the voice, because the more prominent it is, it's actually going to be pulling and altering the shape of the vocal folds, and thus leading to a different tone or a different vibration, that thus creating a different tone, a deeper tone or pitch. So here's the looking down into the larynx, okay, and then the trachea. So this is the larynx. We can see these what they call the vocal cords and the vocal folds. Okay. So this is it's showing the tongue and the epiglottis, but this is our focus right here on the center. So this is the opening in from the larynx down into the trachea. So the your goal is to really just be focused on the vocal folds, vocal cords, and these are vibrating as air is passing through. That's what's creating a variety of different noises. It's crazy, right? How we can talk, create all of these sounds that come from our brain and get them to vibrate these vocal folds in subtly different ways that create. And then of course our tongues are in different positions, and our teeth are in different positions, and our tongue against our teeth and the roof of our mouth and the bottom of our mouth and the flattening the back for certain words. And so yeah, there's a lot going on with language, right? That's pretty complicated. And these vocal cords and vocal folds are what do a lot of the vibrating and creating of those sounds as they leave. Okay. So anyway, that's the larynx. That's kind of again, that's the divider from upper respiratory tract down to the lower respiratory tract. And again, you can kind of see that opening there. The epiglottis would close that lumen or close that opening to prevent food from going down in there. Okay, so next up, we now enter into the lower respiratory tract, and that's going to start with the trunk or the trachea. And the trachea is going to be comprised of different, what we call cartilaginous rings. So they call it tracheal cartilage. They're incomplete rings. So the posterior portion of these rings is incomplete because the esophagus does sit right up against the trachea. And as we travel down the trachea, we're going to branch into two bronchi. We're going to have a left, they call them primary bronchi, by the way, because we do have secondary and tertiary bronchi. So as air continues to flow down toward the lungs, we move into the trachea and then branch over to the left lung and the right lung. So we're going to see the left primary bronchus and the right primary bronchus. Now, you may kind of notice something about this. I don't know. I've been moving this red dot around and babbling, so I don't know if you've noticed this, but we don't have symmetry going on here with these two bronchi. In other words, as the trachea comes down, we don't divide into exact halves. We do see more of a leaning of airflow moving toward the right lung. So the right primary bronchi is a little larger in diameter, and it again tends to be where air. It's basically a continuation of the trachea. You can kind of see that, and then the left primary bronchus is kind of like an off ramp. right? So we've got the main line and we keep going, and then we've got this kind of off ramp here. So the left lung is smaller. The left primary bronchus is smaller. And the reasoning for that is it's simply because of the location of the heart. When we go back to last week, we recall that the location of the heart is a little bit left of center. It's mainly down the middle, right? That mediastinum directly underneath or posterior or deep to the sternum. But we also saw that it's a little bit tipped, and we see the apex and the left side of the heart being a little bit larger and taking up a little more room over on the left side. So we see that affect the lungs, and in fact, the left lung is a little bit smaller than the right lung. So if you were asked a question about, a patient, it could be a child, swallows a marble, but they don't swallow it, that would be bad anyway, right? We don't want to swallow marbles or ball bearings or things like that. You probably shouldn't put those in your mouth. But let's say he inhaled it. He didn't swallow it. He inhaled it. Ooh, or maybe a piece of rice or something, right? While you're eating. So you got to be careful. You got to pay attention. You can't get too excited or upset or anything while you're eating. But the if that marble or ball bearing or a piece of rice, grain of rice, traveled uh, down into the trachea and kept going. If you were asked where would it likely end up, you're thinking right side. Okay, because that's kind of the thoroughfare. Right, primary bronchus is a larger, more of an extension of the highway called the trachea. All right, so I don't want to belabor that any more than I already have. All right, so we do see the primary bronchi branch into what we call secondary bronchi. So you can see a couple more large branches. These are the secondary bronchi. Then we get a few more branches. Those are out here called the tertiary bronchi. And then that leads us into what we call the bronchioles. So this is a bronchiole. Hey, we saw this with arteries and venules, right? On Tuesday, arteries taper to become arterioles, veins, well, capillaries become venules, which then become veins. So the IOLE or ULE or ELLE, that generally means little something. So a bronchiole is a little bronchus. So we just keep tapering and tapering and smaller and smaller and smaller till we get to what we call a bronchiole. And specifically, we branch to the point of having a terminal bronchiole. So when you go outside, especially now, right, all the leaves are off the trees. You can look at like maple trees are really good for this. Certainly oak trees, but you can see the large trunk and then a couple of large, we just keep branching into smaller and smaller and smaller bits till you get all the way out to where the leaf buds would be. So those little branches are called bronchioles, and they terminate at the buds. And these buds are called alveoli. Okay, alveoli. Alveoli. So we'll look at those in more detail in a second. But you can see one is an alveolus, multiples are alveoli, and we can even call the entire thing an alveolar sac. Hey, that's kind of surrounding them. There are little pores and ducts. And the idea is this is where all the air that you're bringing in, this is where it ends. Terminal bronchiole. So the respiratory tract terminates in into these alveolar sacs. These are like little grapes. They're little air sacs. There's what we call a surfactant, which is like a surface lubricant involved that kind of keeps these air sacs flexible and elastic, so they can expand and fill, and then they can contract and empty. We need them to be hydrated. So we do have a surface lubricant there. And then we also see, of course, lots of capillary networks. So what are these vessels? Of course, are going to be pulmonary artery, right? Bringing in blood and branching it into the capillaries, dropping off CO2, and then pulmonary veins grabbing that oxygenated blood and taking it back to the heart. So this is when we say blood gets pumped from the heart to the lungs. Yeah, that's true. That's broad, right? You probably maybe knew that before we ever started talking about cardiovascular and respiratory, but specifically now you guys can say the right ventricle ejects blood over to the lungs, and specifically the alveoli of the lungs where gas exchange takes place, and then we bring oxygenated blood back to the left atrium of the heart. So we go from the right ventricle over to the lungs and then back to the left atrium. So in between lungs is more specific. It's the alveoli. It's the capillary networks of the alveoli. These are the air sacs where the oxygen and CO2 are going to get transferred and exchanged. Okay. So heart pumps blood to the lungs, lungs send blood back to the heart. Yep. Now we can get more specific, or you can. Okay. Anyway, just kind of blowing up one alveolus. Eh, Again, very porous. Alveoli are going to have simple, so let's look at this epithelium, simple squamous epithelium, right? Simple squamous, one flat layer of epithelium. Okay. And why is that? Because we need rapid gas exchange. We do not need to be going through multiple layers. Okay, so the lining of the alveoli is going to be simple squamous. Okay, and then we see the capillaries also have that very thin porous epithelium or epithelial lining. There's no muscle involved with capillaries. So yeah, by the time the blood's in the capillaries and around the alveoli, the oxygen is just going to diffuse. Oxygen goes from high concentration in the alveoli, moves to a lower concentration in the bloodstream. So now the blood has more oxygen. CO2, like all gases, move from high concentration to low. CO2 is in high concentration in the blood, low concentration in the alveoli. So the CO2 just diffuses over into the alveoli as oxygen is diffusing into the blood. So that's a little bit of physiology, but I think you guys can handle it at this point. The very basics: oxygen, carbon dioxide exchange. And again, we look at normal lung tissue and asthmatic tissue. Just a side note, this is more or less just some FYI. Uh, uh, um, COPDs, chronic obstructive pulmonary diseases or disorders, including asthma, chronic bronchitis, okay, emphysema. They have similar appearances. So normal lung tissue, this would be the lumen out here. This would be your pseudostratified epithelium with goblet cells and mucus. And then we've got the basement membrane, and then you've got all that connective tissue and smooth muscle. So we're seeing the same pattern, the same layers that we've seen throughout this semester. Okay, especially when once we started tubes, remember there's no going back. We looked at blood vessels and started going into epithelial lining, connective tissue, muscle layer, and then more connective tissue. So that's what we see here. We've got the lumen, epithelial, connective, some sort of muscles. We're dealing with smooth muscle, right, throughout all of these tubes. Okay, and then more connective tissue. So there's some glandular tissue embedded in there. We've got cartilage. Okay. So asthma attack is going to involve some thickened mucus. So we're going to have mucus starts thickening up and basically blocking the airway. So the diameter of the lumen without all that mucus is a certain size that we need it to be. It's kind of like atherosclerosis. What we saw last time, we saw the clogging of the heart. The diameter just decreases if I start putting a bunch of gunk in there. It's like your plumbing, right? You don't want the lining of your plumbing as it's leaving getting clogged up. Otherwise you'll have a backup, right? So that's what happens with asthmatics. They have they get it's like an autoimmune disorder in essence. The immune system just gets triggered, and then uh, some sort we're not sure what. It could be a variety of items. There's some PTSD potentially involved, environmental factors, there's in utero factors, there's genetic factors, there's so many factors to having asthma, why one has it. But part of it is immune system getting a little bit haywire. So we see mast cells and macrophages, eosinophils, neutrophils. We see something that we don't see up here in normal lung tissue. Okay. So during an asthma attack, all that mucus has been building up and building up and building up, or it gets dumped, and then they hit that constriction, and then that triggers the immune system to kick in. And so this is what we're seeing again with COVID-19, is that we get that the virus comes in and it affects mucus production. And next thing you know, we get enzymes and inhibitors and prohibitors and neutralizers, and immune dominoes just start falling. And next thing you know, it's too crowded, and our own immune cells are triggering more immune cells to show up, and we're converting different enzymes into things we shouldn't. And it's just one big pyrogenic fire inflammatory problem, and it causes a lot of vasoconstriction as well as bronchioconstriction because of all that mucus. So so anyway, we look at some of the more superficial aspects of the lungs themselves. So we made it through the respiratory tract, right? We went through the trachea, the bronchi, then the bronchioles, and finally the alveoli. So let's just look at the lungs themselves. We see again, the right lung is larger. It's broken up into three distinct lobes: the superior lobe, the middle lobe, and the inferior lobe. Okay, and then the left lung again being slightly smaller, we do see just two lobes, the superior lobe and the inferior lobe. Okay, so we call this little groove the cardiac notch. You can almost see where the heart would fit right in that little spot. Okay, so again, we've got the main left primary bronchus, then we have secondary bronchus or lobar, and then we get down to the tertiary bronchus. They also call them segmental bronchi, or call those segmental bronchi. So we have main, lobar, segmental, or primary, secondary, tertiary. Okay. And then we look at some of the muscular. So we're kind of working our way out even further. We do see, so we'll look over on the left side first, or our right side, patient's left side, right side of the screen, left side of the patient. We do see, thank you. We do see the lungs having, or the thoracic cage being removed, so we can get a better look. This isn't normal, right? We don't have the left side of the rib cage isn't gone. It's definitely there. We've just removed it for effect, so you can see a little bit of the pleural sac that's involved. We saw the pericardium with the heart. We saw the visceral and parietal pericardium, and now we look at the pleura, is the kind of membranous double layer that we find with the lungs. And of course, in between each of those layers, we do find a pleural cavity. So let's take a look. We see a rib here and some intercostal muscles. So yeah, we took the ribs off, and now we're just blowing this little square up. And we've got this most superficial layer is the parietal layer. And then remember, viscera means organ, right? Or guts. So visceral layer is always going to be right up against the organ. Okay, so the visceral pleura and then the parietal pleura. In between those, we have the pleural cavity. This will play a role next semester. We're going to look at a case study, and we're going to discuss. We're also going to do a virtual physiology lab that deals with something called pneumothorax, where we get a puncture of the lung and a deflation of the lung, and so we'll take a deeper look at these pleural cavities and these pleural membranes next semester. Now, the parietal pleura is going to basically be the inner lining of your thoracic cavity. Okay. So we see the thorax and the thoracic cavity. That parietal pleura is right up against the underside of your rib cage or your thoracic cage. As we go down and we see the diaphragm as well, that parietal pleura is also going to be what's attached to the diaphragm. So the diaphragm is going to have, because it's a muscle, right? The diaphragm is just kind of like a skeletal muscle. It's going to have fascia running over the top of it, and then you're going to have that parietal pleura right on top of the fascia of the diaphragm. So every time the diaphragm flattens out, you can see the central tendon here. When the diaphragm flattens out, it's going to pull the lungs with it, and we're going to see the lung volume get larger, and that's going to create a pressure difference and allow air to come into the lungs. So we need the diaphragm to be able to flatten to pull the lungs with it. We've talked about this before. We started talking about it way back when we were doing the phrenic nerve and the nervous system and how important it is. Actually, even before that, right? We were talking about the diaphragm and we were doing skeletal muscles and some of its actions, which are to help with 75% of the ability for you to inhale is because of the presence of the diaphragm. The other 25% of your ability to breathe is due to these other muscle, the intercostal muscles. We have a few other scalenes and so anyway, so you've seen diaphragm all the way back to skeletal muscles. We brought it forward, continued to bring it forward with the phrenic nerve, and now here we are with we finally made it to the respiratory system. So this concept and connection and link, the concept of connecting and linking the lungs with the diaphragm, you guys already know that. You've known that for several weeks now. But now we get to actually see it in full force. Okay. And then we have, of course, these other intercostal muscles that are going to elevate the lungs and or elevate the rib cage and depress the rib cage as the lungs either fill and expand or empty and contract. And we also notice, look at this, the kind of the apex or the peak of the lung. Look how high up that is. That goes above. Here's your clavicle right here. They don't show it, but you can see the sternum here. The clavicle kind of comes over here. So that first rib kind of dips underneath the clavicle. Okay, still protect, but yeah, the top of that lung, that little blob right there, that apex, that's kind of, it's like above the clavicle. That's kind of a sensitive area right in there. And the brachial plexus is in this area, the carotid arteries in this area. So this is a kind of an area we generally kind of avoid doing a lot of palpation with. Okay. Well, here's just another look in more diagrammatic of a frontal view. This gets into some pressure stuff and physiology. So I don't want you guys to get hung up on this slide at all. I think, in fact, that pretty much does it, because from at this point on in the chapter, it's all physiology. So we're just going to put on the brakes. So that's all I have this morning. I guess now it's afternoon, but so heading into the weekend, keep working on Unit 7. If you're still working on Unit 7, Unit 8, you should be fairly into Unit 8 at this point. And now we just started Unit 9, so I don't expect you guys to be doing really much of anything with this yet, except again, just being introduced to, or I guess not really introduced to, I mean, reintroduced, or we're just segueing another puzzle piece from cardiovascular into respiratory. By the way, too, lymphatic wise, we do see a lot of lymphatic vessels, lymph nodes associated with the respiratory system, because this is the number one way of transmitting some sort of pathogen, is the respiratory system. So we definitely need a lot of lymphatic tissue associated with the respiratory system. Okay. You guys have questions or comments or concerns, anything that you need? Okay.